Welcome to the HTLL podcast. We are your co-hosts, Emily Hirata, Technical Advisor for Health and Nutrition,
and Tino Movuti, Technical Advisor for Water, Sanitation and Hygiene.
In our last episode, we chatted with Michael Peach, the Global Emergency Coordinator for ADRA's network-wide global response to the COVID-19 pandemic. For today's episode, we will be sticking with the theme of outbreaks and pandemics, but we'll be shifting our topic to Ebola. While COVID-19 has gotten most of the coverage over this past year, Ebola is still very much a threat. In fact, it has recently sprung up again in a few places. With this in mind, we thought it would be interesting to hear from some fellow ADRA colleagues on their past experiences with Ebola response, both while working for ADRA as well as working for other agencies. We have with us Dr. Etienne Longe, Country Director for ADRA DRC, Dr. Yav Gushimana, Associate Director of ADRA DRC's East Zone, and Dr. Nisar Ul-Haq, Health and Nutrition Coordinator for ADRA Yemen. Both Dr. Longe and Dr. Gushimana have been involved with ADRA DRC's response to Ebola outbreaks, while Dr. Nisar was involved with the 2014 to 2016 West Ebola crisis response while working for IOM. We are eager to hear the experiences and perspectives of these three gentlemen today. Dr. Etienne, Dr. Gushimana, and Dr. Nisar, welcome.
Thank you, Emily.
Thank you, Emily.
Thank you, Emily.
I'm just really excited to have all of you here. I think this episode gets the distinct honor of having this many doctors from all the episodes that we've done since we started this series. It's just really exciting to have you all here and to hear about your experiences. To get us started, we wanted to ask all three of you what your role was in responding to Ebola. When was it? Where were you located? And what exactly did you do? Dr. Longe, would like to start with you. Could you please tell us about your experience in responding to the Ebola crisis?
Okay, thank you, Tino, for the question. I'm the country director. Then the Ebola response for me starts when the information comes. I need to share that information with the HT, especially the emergency team. And from there, we discuss how to put in place the first intervention and then also contact other partners for fundraising. And I work also sometime on the field for the visit, just to do the monitoring and the evaluation of the intervention in the North Kivu epidemic.
How about you, Dr. Gushimana? I know you're also based in the DRC. What was your experience and what was your role in responding to Ebola?
The epidemic of Ebola virus disease in DRC began in the province of North Kivu, where I am now, on August 1st, 2018. And this epidemic lasted for more than 24 months. At the time, I was in Kinshasa, but in February 2020, I was deployed to Goma just to support the team in the field. It's ADRA, I am the program manager, but also the associate director that you say. And for this response, I continue to support the field teams in the coordination of the response that we had in the response to this epidemic. There's are the nutrition, health, and food security projects specific to this Ebola epidemic. So my role was also in the fundraising through the writing of a project proposal and the concept notes.
Thanks for that. Dr. Nisar, we understand you were in a different region of Africa. Could you tell us a little about what you did?
Yes, I was involved in the Ebola outbreak during 2014 in West Africa. I was based in Liberia. I was a medical coordinator for a 100-bed capacity Ebola treatment center in Bomi County. And I was involved in the direct management of Ebola cases. And later on, when we closed the ETU after Liberia was declared as an Ebola-free country, we established mobile clinic teams to support the Ebola survivors and also the vulnerable groups in the community because of the health system was affected by the outbreak. Later on, I was also involved in the transitional phase of Ebola outbreak in the region, and I was leading one of the subsector in Liberia, covering 3 counties as epidemic preparedness and response coordinator, where we were working with the county health teams and with other partners just on the strengthening of the health system for epidemic diseases. So I worked almost 3 years, starting from the initial emergency response, transitional phase and recovery phase for the Ebola outbreak.
Given that involvement by all 3 of you, I'm sure you learned quite a bit from these experiences. Dr. Longe, Dr. Gushimana, you were based in the same ADRA country office. So I'll begin with you. What are some important takeaways that you learned from your experiences with the past Ebola interventions with ADRA? Dr. Longe, could you respond to that one?
There are several lessons we learned in our past experience in the Ebola response, working in DRC outbreak. The first one is the involvement of all stakeholders. We saw that when the community, it means the authority, also religious leaders, when they are involved, things can go very quickly and very good. But if we are not able to involve them, they will be systematically against the project and the outbreak. This has been the case for other also partner in the field. Another point important is the partnership. We need to work with all stakeholders in place and to have very clear role and function in the response. Another lesson is we cannot forget that the project, we are coming to help the community. Then you cannot work for me without me. We need to know that the community and the beneficiaries, they are the key element for the success of the outbreak. Also, working in the consortium with other organizations help to learn from each other. But during the Ebola in DRC, we also learned that a multi-sectorial response is very important in terms of not only health, but you need to see what is the WASH component of the response, what is the food security component, and also you need to work very strong on all things about protection, about sexual abuse, sexual exploitation, and other transversal themes. Another big lesson for DRC was the impact of the vaccination. The vaccination give also some impact in terms of prevention of the disease. But when you are working also, we learn that if we put a free medical service in a community, we are able to respond and to prevent not only Ebola, but also some other disease like the non-communicable disease, like diabetes, like high blood hypertension, and other diseases.
Dr. Gushimana, do you have something that you'd like to add? Were your lessons any different from what Dr. Longe has just spoken about?
I think this is the same experience, but what I can add is it is about the collaboration with other partners for the response, because it is difficult that a single one organization to implement or to give a good response. But I think the response, when we need to have effectively response in the situation, the complementarity is very, very important for an adapted and effective response. This is a good lesson for this last epidemic of Ebola virus in DRC.
Dr. Nisar, since you were not working for ADRA, but rather a very different organization, I'm eager to hear what your perspective on this is. What are some key takeaways that you gathered during your response to Ebola in West Africa with IOM? Were they any different from what Dr. Longe and Dr. Gushimana have just shared?
Yes, it was a little bit different as I told you that I was involved directly with the management of the Ebola cases, and in that regard, my takeaway are different from Dr. Longe and Dr. Gushimana. So I will start with the case management of the Ebola patients, because when we started, the case fatality rate was very high in the region. But later on, what we learned that the aggressive early diagnostic and the treatment is making a lot of difference. If people are coming to the treatment centers on time in the early stages of the disease, the prognosis are much better instead of people who used to come in the third stage with the hemorrhagic symptoms, where the prognosis were severe. So aggressive supportive treatment with the psychosocial support for the patients and for their families, it made a huge difference. And in our ETU, we were one of the leading in the region with the survival rate. We managed to treat 85 patients, and we had only 11 deaths in the treatment center. So it was quite good in the region, and it was just because of our approach in terms of aggressive support for the management of the cases. And also, I would say the community leaders' involvement, because the county where I was working, it was like a Muslim community and at the same time the Christian community. So we used to bring on board the pastors, imam from different communities, and even our psychosocial team. It was consist of different category of people, imam, pastors, and some consultant from outside, and they were really doing well with the patients. And also at the community level, the acceptance in the beginning was almost zero in those communities. They were not accepting that Ebola is real, and the INGOs or the UN agencies are there to support. So, but later on, when the community elders, imam, pastors, and the community chief, they went with the teams to the community and explained them, it was better, and then we received a lot of support from the community. And also they started active case finding at the community level, and if someone was getting sick, they used to refer those patients at early stage as possible. Also, I noticed in Liberia, I traveled also to Sierra Leone. I was working in the region, so we used to have some coordination meetings at the regional level, where all the three countries, Liberia, Sierra Leone, and Guinea, were sharing the experience. So what I saw in Liberia, and which really also had a good impact to control the outbreak, it was the screening at the checkpoints and at the point of entries. So the authorities, they were having strict screening at different point of entries and at the checkpoints. If any suspected case was found, they immediately call the hotline for the referral. So it really helped. And also at these checkpoints, if you are traveling in any transport, people were requested to come out and wash their hands, and the temperature was checked. So they were doing a proper screening, and it really helped. So these are two main lessons learned which I would like to share with you. And I will not talk a lot about the community involvement, because Dr. Longe and Dr. Gushimana, they made their contribution on that, and I totally agree with them that without the community involvement, it's difficult to make the contribution at the community level, and people will appreciate if you have the penetration through their leaders, through their elders, they will welcome.
There is now a new wave of Ebola. I think the DRC identified their first case in mid-February, and there's rising fears of a fresh outbreak of this deadly disease. Guinea as well. How do you think the lessons you've learned so far, Dr. Nisar, can be useful in the fight against this new wave of Ebola and any future pandemics of Ebola that are yet to resurface?
I would suggest the community engagement will play a key role to do the screening at early stages, and if they start the screening at early stages at the community level, so that they can refer more people with signs and symptoms to the treatment centers with the early stage, so the prognosis will be better. Also, the hand hygiene practice, it will be having good impact on controlling the disease.
And Dr. Longe and Dr. Gushimana, how do you think the lessons that you have learned in the fight against Ebola in the DRC, how do you think that is going to become really useful in fighting against this new wave?
I think that new outbreak of Ebola, we have more elements to fight against than in the past. The Ebola is, the disease is quite in the same region. All communication matter about Ebola are a little bit easy because our population, they know already how to be with Ebola daily. And all the past successful as lesson learned are helping the new outbreak now team to have a very good control of the disease. Then the epidemic is well under control now, due to the fact that the population, they know already, and also medical staff, they know already what to do in when you are fighting against a Ebola virus disease.
Dr. Nisar, you had mentioned a little bit about misconceptions in West Africa and working with religious leaders, community engagement, those kinds of things. Dr. Longe and Dr. Gushimana, I'm interested to hear from you about how ADRA got involved in DRC regarding rumors and misinformation. And if you weren't involved with that, is it something that you think we should be involved with for future outbreaks?
I think for ADRA DRC, yes. ADRA was involved in this issue about rumors and misinformation. I think we had two projects funding by UNICEF and the Australian government to implement at least the project based on behavioral change communication. This is to give the right information to the community. As you know, the big problem with this region was about the information, the good information, and the strategy has been quite effective because we have been working with the communities at the local level. the good thing is the advantage of ADRA is that it is a faith-based NGO, and it has been easy to work with a religious community of any faiths, Protestants, Catholic, Muslim, and other.
Dr. Longe, do you have anything to add regarding the DRC context and rumors and misinformation?
In DRC, there was rumors and misinformation, and that led to the clash between humanitarian team and the community. And that's why we come up with other response regarding strongly the management of the information and also the implication of the community leaders in spreading information.
Dr. Nisar, you had mentioned just a few minutes ago that in West Africa, there was psychosocial support that was being provided for beneficiaries. I'm in those communities. I'm curious to know how you, as the humanitarian workers there, kept control over your own mental health and psychosocial well-being. How did you strum up the courage to continue working? What kept you going?
It was really difficult to work in that environment at that time because the outbreak in West Africa at that time, it was not having a lot of SOPs on Ebola management, and there was a lack of SOPs and guidelines, and even the treatment protocols were not lacking of treatment protocols. They were available, but still it was not sufficient. And also challenges with supplies and the caseload in the units were quite high. So in our team, we had the psychosocial coordinator and some officers, and time to time, they were doing group counseling of the staff, and also sometimes individual counseling with some staff who as needed. And we also used to have like a kind of staff welfare or over the weekend when we have less work. So the colleagues, we used to just come together, and then it was informal kind of counseling by our colleagues from psychosocial department. And also the social life was not that much because of the restriction due to the Ebola in the country. But later on, we used to collaborate with other NGOs and partners in the county, and it was also like a session of sharing the information with other partners, but also it was helping you to boost up some time, and you just meet with other people. So, and we had the R&R cycle, which was very, very short. During the heat of the outbreak, it was 6 weeks, and you can go and take some rest to see your family. It was also boosting and supporting.
Those are some great ways to help boost the psychosocial well-being of staff. Absolutely. I can't imagine how difficult it must have been. Dr. Gushimana and Dr. Longe, same question for you. How have you been able to keep it in high spirits, psychosocial well-being? How have you taken care of yourself, or how have you been able to provide for your own staff there in DRC?
You know, when there is a Ebola outbreak, it is a very difficult time for medical staff, but also for other staff. And as leaders, you need to come up with very good information or very good speech to do the sensitization of all your team. And for our team, most of us are a little bit working as staff, medical staff, and we was talking to them that for us, the response to epidemic is part of our daily obligation as medical staff. But also, we put in place some strategy, like when we are sending all our staff in a Ebola locality or Ebola community, they need to have vaccination before to go. But also we need to give them all information about the prevention, and also tell them how it is important as ADRA to work with compassion and love. Because if you just read the rate of lethality for Ebola is so high, then even a physician can refuse to go and work in that kind of intervention. I think that is something we was working with our team to keep them motivated for the work and for the response.
Gentlemen, as we wrap up, one more question for you three. We would be remiss if we didn't mention COVID-19 in this interview. And I'm sure there are several parallels between Ebola response and COVID-19 response. So from your perspectives during Ebola response, what are some things that we can also apply now during COVID-19? Dr. Nisar, let's start with you.
Yes, there are many things which can be implemented during the COVID response, and I will again start with the community approach. I will share with you some ideas from Yemen, because still in Yemen, people are denying the existence of a COVID in the country. So the community engagement is it's really good to do the awareness, because here what we have observed that the people go to the health facilities only when they have developed already signs and symptoms, and even at the critical stage when they go to the health facility. And that is one of the reasons Yemen is having one of the highest case fatality rate in globally at this time, which is more than 20% of the positive cases. That could be improved by emphasizing on the community engagement through different levels. And also the hand hygiene is very important. Just by washing hands, you can protect more than 50% of chances that you could avoid getting the infection. Hand hygiene and respiratory hygiene could play a significant role for the COVID response. I think these two are most crucial, what I would like to share.
Yes, thanks for that. Dr. Longe and Dr. Gushimana, anything else to add?
For adding to Dr. Nisar's response, for me, first of all, it is the question of the good communication about the disease and the involvement of the community and based through the community organizations. But also, I think we need to capitalize on the accomplishment of the past response in Ebola. But if we analyze where the big problem of the past response in DRC, it was the dissatisfaction of the community, of the population. So for me, we can capitalize two things. Firstly, the community involvement, participation. We need to involve the local community more in the response that we need to give. Also, the need assessments. For the need assessment, we must not focus on response to the disease while forgetting the other needs of life that makes the community vulnerable. Therefore, the occurrence of an epidemic, whether Ebola, COVID-19 or other disease, we must always have an appropriate multi-sectoral response that addresses the other urgent needs of the community.
Dr. Longe.
Ebola response, COVID-19 response, they are just a little bit the same. It's just the difference of name. The past response in Ebola helped a lot in the area we are working in North Kivu because we was already doing community engagement. And for now, about COVID-19, we are doing the same. And we are also adding social distancing measure and a wash component. But also we are working in the vaccination. It means we are doing already the sensitization to the population to accept the vaccination. And that was the same during the Ebola outbreak. At the beginning, it was not very easy to convince someone to be vaccinated. I think responding to Ebola and now to COVID-19, we are doing quite the same work, and the work is less easy, especially in the area that we was working before for Ebola, because all sensitization campaign can go easily now with COVID-19.
Thank you. Great points. Gentlemen, it is time for us to wrap up, but we want to thank you so much for taking the time to speak with us today on your experiences during Ebola response. It's been really interesting to hear about your thoughts and perspectives and the activities you carried out, both internally with ADRA and externally outside of ADRA. So just a big thanks to you for being willing to share with us today and with our listeners.
If you would like to learn more about ADRA's Ebola response or other topics regarding health, nutrition, and WASH, feel free to contact the Health Technical Learning Lab at healthtll@adra.org. To listen to other episodes of the HTLL podcast, please find us and subscribe to us on Apple Podcast or Google Podcasts. Thank you for listening, and join us next time for another episode of the HTLL podcast.